4 or 5 months back along with and
Wait, chasing the teeth that go with that?
yeah. He was like, just I think I just got my and I'm like, I'm not getting involved in any of that. Are you crazy? I'm not that little much yet.
Yeah, you can. We're good.
All right, everyone, we're going to get started. Thanks, everyone, for coming tonight. Dr. Stephen Stache, he's our non-operative sports medicine physician. He sees patients at our Bryn Mawr, Newtown Center, and New Hampshire offices. He's speaking tonight on non-surgical management of knee osteoarthritis. But do you want to ask questions till I ask?
Yeah, no, they can ask them as we go.
You can ask questions as we go, and then at the end of the evening, Dr. Stache will be around as well, if you have any individual questions. So, I'm just going to introduce Dr. Stephen Stache.
Well, everyone, thanks for having me tonight. I really appreciate the opportunity to be here. Blue shirt guy in the back there. I'm going to point you. If you guys can't hear me, get your hand up. I want to know, okay? I'm going to do my best. I'm usually pretty good, but if you think I'm trailing off, just give me some of that, and I'll make sure I speak up, okay? So just to give you a little bit about myself, I am originally from the Pittsburgh area, so I'm a Steelers fan. So if you're an Eagles fan, give me a break here, okay? NFC, AFC thing, it's okay. We only play once every 4 years, so I still appreciate the Eagles. The Flyers, on the other hand, not so much, but I don't want to digress. We'll try to keep it all collegial here. I came to Philadelphia, started a medical school at Jefferson, and then I stayed on for residency and fellowship. I did my initial training in primary care, so I'm not a surgeon. So if you ever come to see me or any of the colleagues who kind of operate the way that I do, the goal is to always look at the condition, understand all of the options and what the treatments are that are available. And then if surgery is indicated, that's certainly something we will discuss. But the nice thing about orthopedics is, with the exception of severe fractures and other more concerning injuries, a lot of the stuff is elective. And so I like to start my talks about arthritis because I get so many questions about knee replacement. And I always lead with the discussion that you have to remember that it's an elective procedure. No one ever needs a knee replacement. You eventually want a knee replacement, okay? And that's an important concept because when you take that perspective, a lot of times it takes away from the fear and the life-changing aspect of it. Oh my gosh, my knee is bad, and I've been told I'm bone on bone, and I'm terrified of this procedure. And what it really comes down to are two things: pain and quality of life. And we'll touch upon this a little bit later in the talk, but I always like to kind of give that perspective that I'm not here to push any one particular medication, one particular injection, one particular device or surgery. My goal as a non-surgical sports medicine orthopedic provider is for every patient to understand their options and have a plan in place to help control pain and maximize function and quality of life. At any time, if there are questions, feel free to stop me, but I will be sure to give time for questions at the end. So overview, I think that there's a lot of misinformation, or there are some confusing things about the knee and the anatomy that if you don't understand a little bit about the knee, it makes it a little bit more challenging to understand arthritis. Then we'll go through some of the non-surgical management options, and we'll talk about some other adjunctive therapies at the end. I could certainly answer any questions on knee replacement if that was interesting to you guys, and then I'll give time for question and answer. So knee anatomy. Did I click too many times? So when you're in medical school, when you take anatomy, it's very easy to think of the body in layers. The first layer of protection is our skin, okay? And then there's the subcutaneous tissue, which for a lot of us as we age, there's some fat in there, and that's normal, some more than others, but again, that's just the way it goes. Then we start to get into the muscle and the other soft tissues, and then down to ligaments and bones. So when you think about the knee, it really comes down to those structures. Arthritis is a bone and cartilage condition, okay? And it tends to affect both over time. Now, what we're going to talk about is osteoarthritis, which is different than rheumatoid arthritis, okay? Rheumatoid arthritis is an inflammatory condition tibia are the weight-bearing articular surfaces, which is where additional cartilage lives. And there, I don't know if I have a pointer here that you'll see. There's the medial compartment. You guys can't see that, can you? I don't even see it. There's the medial compartment, which is on your far right, and the lateral compartment. The fibula is the second shin bone, really doesn't involve itself in the weight-bearing surfaces of the knee. It's more important for extremity stabilization below the knee and as part of the ankle. Then there's the articular cartilage, which is the white stuff that you see on the end of the thigh bone or femur, and then there's the meniscus. These are two shock-absorbing pads that live inside the knee. We'll spend a little bit of time talking about the meniscus later because a lot of people get hung up on that meniscus, on the process of the arthritis condition, and oh, I was told I have a meniscus tear. What can be done about that? We're gonna touch upon that in great detail because I spend a considerable amount of time in the clinic differentiating between acute meniscus tears versus chronic degenerative meniscus tears. On the left side of the screen, you see some of the muscular structures that are responsible. You have your quad muscle, which is important for knee stabilization. So a lot of times we talk about the importance of muscular strength and stability in the treatment of arthritis. And this is designed for one specific purpose. The stronger your muscles are, the less stress there is across the bone. So a lot of times patients will describe a scenario, doctor, I wake up in the morning and my knees are killing me. I start to walk around, I feel like I'm loosening up a little bit, and now my pain starts to get better. That's because the muscles are waking up and starting to share some of the burden of the stress across that weight of the joint. Moving forward, it's important to understand what happens to cartilage over time. Everyone's familiar with tire treads on a tire, right? If you run a tire, over time tend to wear behind the kneecap. And I'll show you some X-rays that I think will help make that sit a little bit better. But it has to do with male versus female anatomy. Women tend to have a little bit wider hips so that the childbirthing process sometimes, most of the time, hopefully, goes a little bit easier versus men who kind of have more of the box frame. And that affects the way that forces are distributed. I pause there to comment on weight, okay? The weight that we carry around gets transmitted through our lower extremities with every single step that we take. So it's a very important concept because as we become wiser in our years, one of the gifts in nature is it's a little bit harder to keep the weight down even if you're staying on top of your diet and exercise. That's just a natural process of aging. And so every pound that you can lose if you are overweight is really equal to about 2 to 3 pounds of force distribution per the knee.
I have a question.
Mm-hmm.
Do you do weight training without the legs?
It's a great question, and part of what I'll talk about in a minute with some of my treatment is, yes, there is some realm for actual weight training. We're not talking that you got to start looking like Arnold Schwarzenegger here in his prime in the 70s, but some of the forces that can be improved as far as muscle strength in the legs will help mitigate some of the stress. It's a very delicate balance as how much is too much when you're talking about weight training. So a lot of times I don't refer to it as weight training. I refer to it more as resistance training. Something as simple as a resistance band, and a lot of people are familiar with those, can be enough to stress a muscle just a little bit more to give it the ability to grow and stay stronger, which will then help decrease some of the stress across the bones. So what you're looking at here in this picture, that's a great question, by the way, is kind of the comparison between a knee and the articular cartilage, which does tend to wear over time within the knee. I often say that getting arthritis of the joints is kind of like getting gray hair and wrinkles. It will happen over time. And despite your best efforts to take care of yourself externally, many people develop it. And some people develop gray hair and wrinkles at a very young age. Some people don't get it until they're later in their 80s, 90s, and very few fortunate people never really develop it to some degree. But the idea is that arthritis is a condition that can start and be going on without you having symptoms. And for any particular reason, injuries, you were working in the yard, you fell, you twisted. I could go on for the entire time here listing reasons that you can get a pain flare from the arthritis that has been slowly developing in the background. So the formal definition is osteoarthritis, also known as wear and tear or degenerative joint disease, is the most common form of knee arthritis. It is usually a slow, progressive, and again, that word degenerative comes in there, which the joint cartilage wears down and then can start to affect the bones below. One of the terms that some people are aware of is something called bone spurs. Okay, bone spurs are a natural process of the joint wearing down where the cartilage can't mitigate the forces as well anymore, and the bone tries to harden itself. But since we're always moving and we're always doing different things, the bone can't strengthen itself in a uniform manner, so you start to get these little bone spurs that form. Again, normal part of the osteoarthritis process. Symptoms, and it can be any or all of these, and I'm sure there's a couple that I probably haven't included on the slides that you could all shout out that you may or may not have experienced or know someone that has experienced. But pain with walking or activity, pain with sitting for long periods of time or stiffness, pain going up and down steps or both, swelling, and this is an important consideration. Pain and swelling can come together or they can be totally separate. I see plenty of patients that say, "Doc, my knee's not that bad as far as pain, but it's always swollen and it drives me crazy because it's stiff and I can't bend it the way that I want to." That's because the inflammatory process of the tissues not responding to the stress as well can cause either pain or swelling or both. Worsening of pain during activity or exercise and sometimes after. And then the symptom of buckling. This is another one that I get a lot. "Doc, my knee gave out." Typically what happens is there's no structural compromise of the knee. The ligaments didn't tear. The knee structurally itself didn't give out, but the knee gets put in a position where pain suddenly overwhelms the lower extremity's ability to stabilize, and the muscles for one brief second shut down in order to protect itself. A lot of times they can happen on the steps, and this is where that strength consideration comes into play, because the stronger you are, the more stress you can handle, the less likely you are to experience that little buckle where you felt like your knee gave out. Here's the one thing that literally keeps a lot of people up at night is night pain, okay? And it's challenging because there's a couple things working against everyone that has night pain. One, it's a culmination of everything that you've done during the day. You're trying to take care of your house, you have to work, you're chasing your grandkids or your children around, and all of that tends to build over time. Then, unfortunately, paradoxically, our internal sense of inflammation, our body's pro-markers for inflammation tend to be higher at night. And so that then kicks in. And then you're trying to shut down to go to sleep. So you're relaxing. So you tend to be a little bit more aware of your body and what you're feeling because you're not running around trying to do 50 different things. And so really a combination of those three tends to lead to a little bit more of the night pain, which is a considerable life quality burden, because if you're not sleeping, that negatively affects your quality of life during the day, and restful sleep allows for recovery. And that's another important process that happens, unfortunately, sometimes with arthritis. So as I mentioned before, injury does not necessarily have to be part of the process to worsen symptoms. My analogy, and I use analogies all the time to help explain things. Imagine, if you will, that there's a slow leak of sand, imperceptible to your eye for any one particular pebble of sand falling over time. Eventually, there's going to be a giant pile of sand, and you may be so busy that, again, you're not noticing, and then you turn and look and say, "Whoa, where did that pile of sand come from?" That's what happens to the inside of the knee. It is slowly breaking down over time. And then, again, for no particular reason, or an injury, or you overdid it at the gym, you got pain. And that's when you want to start to think about the options and what you need to do to help control this. Because that's the hardest part about arthritis. Once it sets in, you cannot undo the damage that's been done over time. A lot of the newer techniques that you read about talk about the promises of reversing cartilage breakdown, the more fountain of youth promise. Science is not there yet. And when you're in your 50s, 60s, 70s, or beyond, and you have significant arthritis, that is not the time to intervene with trying to help stop things as they happen. It would have been earlier, which gets a lot harder because we have to live our lives, we have kids, and life gets in the way. So what happens? This is a picture that illustrates the breakdown, okay? And eventually, cartilage can break down to the point where it wears through and the bone gets exposed. Bone is living tissue. It changes over time. There's blood vessels, and bone can shrink, which is why sometimes we lose our height as we get older, okay? Mostly in our spine, but also in some of our long bones. And once the cartilage is gone, bone can become very sensitive to all those forces that I mentioned earlier. And when bone becomes inflamed, you're going to know it with pain and potential swelling. The picture that I have on your right is kind of referring to that uneven wear that we see in mostly men, but sometimes women over time, where because of the way forces are distributed, you get more wear on that inner part of the knee. And you can see here that the cartilage on the outside, again on your left, nice and clean, has a very uniform appearance to it, pearly white, if you will, as opposed to the other side where you have that red kind of mottled appearance. That is pain and inflammation settling into some of that tissue there. And that's equivalent to the uneven wear on the tire. Battery popped out. Sorry, guys. There we go. Okay. So X-rays. X-rays are the diagnostic tool that we use to understand the severity of arthritis. This is a very important concept because a lot of people get hung up on their X-rays, but I say this to patients in the clinic all the time. I do not treat X-rays. I treat the patient. I've seen plenty of patients that have severe bone-on-bone arthritis that come in and say, I just kind of wanted to know what's going on with my knee because it bothers me every now and then. I still work, I still play golf, I still do the things that I like to do. And I look at their X-rays and say, wow, this is pretty significant. I'm impressed that your pain isn't that bad. Then I see other patients that have very mild changes, but their pain can be very severe. That's a much more complex topic than I really have time to go into right now on how and why that all shakes out. But suffice to say, we use the X-rays to help guide our decisions. Ultimately, it's the patient's pain, decrease in function, and quality of life that really drive what we do. Does that make sense?
Yeah.
All right, so this is a normal knee, and I'm actually going to come over here and point a little bit because in this space that you see between the bones, that's where the cartilage lives. Now, we can't see the cartilage, but we know it's there, and we infer by the fact that the space is there fairly uniform that there's no significant arthritis in this picture. Okay? When you look over to your right, you can see that it's a side view. You're looking behind the kneecap, and you can see the dark line that signifies there that space is still there. This bottom view, it's something called sunrise. It looks like the kneecap is rising over the horizon. This is where we're able to look behind the kneecap, which is often the source of issue for a lot of women. And this can be very frustrating because I've seen plenty of women that in the past have had some sort of knee scope procedure to address their meniscus tear. And doc, I'm still having pain. Well, that's because you have bad arthritis behind your kneecap that cannot be addressed with any kind of meniscus procedure. I hear that story, unfortunately, fairly often. Moving to what we consider mild arthritis, okay? When you're looking at the weight-bearing picture here, you can see that to your left, the space is starting to be decreased on the inside of the knee, as opposed to the outside where there's still some pretty decent space, okay? This is a very common finding in early arthritis. There's still some level of space between those bones, but it's starting to change, meaning that it's getting worn down. When you look on the lateral view, as we call it, you can see that at the top of the kneecap, you're starting to see a little bit of a point where previously it looks a little bit more smooth, okay? Bones in your knees should never come to a point. Only really the tips of your fingers and toes are where bones are naturally supposed to come to a point. Everything else should be much more smooth. And when they don't, we know that that's part of the bone spur arthritis process that can start to give symptoms. When you look at the image down here on the lower right, you see that there's a difference between the space more on the inside, on the outside and the inside, where this is starting to wear down and there's less cartilage in that spot. And anytime I see that, this is a potential pain generator, okay? Because the cushion isn't there as good as it used to be, and the friction and forces are going to be distributed differently, which can cause inflammation, which leads to pain, swelling, and some of the limitations that we talked about in an earlier slide.
Can you see the meniscus on the inside or just the?
You cannot. But in the same way that I have said, we infer that under the normal knee, we know that it's there. Unless you had some sort of procedure, which typically doesn't happen anymore, where they take it out. You may trim a portion out, but even then you'll still see the space, okay? The only way that you can truly see a meniscus is on an MRI, which we'll talk about in a minute. So mild, you kind of get the sense. Now we're going to move to moderate, okay? Now, when you look at this, and I know I flipped to the opposite knee, it's a little confusing, but I wanted to get good examples. And you can see here the inside of the knee is to your far left, still some space, but now on the outside of the knee, you're starting to see less space. There's only a little sliver of black. And again, I wish I had a pointer. Right here is some bone spurs that are starting to form on the outside of the knee as a process of the forces that are being delivered to the bone and it not being able to handle it. Here, up here, you see that, look, there's a big point now, okay? And that's starting to form over time. That's a bone spur. The rest of the bones don't quite look as smooth. You see these white lines that are starting to form here? That's something called sclerosis. That's the bone hardening itself over time, becoming more dense because of the increased forces. And then when you look again behind the kneecap, look how much decreased space there is now. You get a nice bone spur out here. Again, this is very common with time, more frequently in women. And then to transition to severe OA, that bone on bone. Good.
Transfer some of that stress where you see uneven wearing using different inserts.
So that's a great question. That's where we get to talk about devices, which I'll touch upon as we go through the different treatment options. Devices, less with inserts in your feet, but more braces at the knee, can be used. There's something called a lateral unloader brace, which basically attempts to realign the knee ever so slightly to help open up the space. Now, the problem is it's a device. You have to wear it for it to be effective. Some people don't like that because they don't want to be dependent on this thing. However, knowing that we can't take this away, we can't fix this problem in the manner that you want it to be fixed, meaning just kind of make it how it was, it's not a bad option that can often be very successful in helping treat symptoms over time.
What was that device called?
It's an unloader brace, okay? And there's both medial and lateral unloader braces. So in this image, this is the medial compartment. You could wear a brace that supports the inside of the knee that shifts some of the forces to the outside of the knee. And in this picture, this is a lateral arthritis. It would be the opposite, okay? And that would be where somebody, you would see someone like me, we would talk about it, we'd talk about your options, and if it was something that you were interested in, that's something that we could easily get you set up. There are a number of different companies, DonJoy is one of them, that make these braces that can be very effective in helping people over time. The kneecap gets a little bit harder. There's really not a brace that's going to shift the kneecap the way that you want it to, that's going to really offload the stress, because every time you bend your knee, that kneecap is riding in the groove. So this is the end stage. This is severe arthritis, what we call grade 4, because it's on a scale of 0 to 4. I just showed you 1, 2, and kind of moving into 3, but this is 4, okay? This is bone on bone. You see here in the medial compartment that there's no space left. Up here, there's a lot of what we call bone spurs or osteophytes. When you look behind the kneecap, you can see barely a line, and look how bendy it is. It doesn't follow any kind of nice contour. This is what we call bone erosion, This tends to be a very painful condition. Options tend to get a little bit more limited when the disease becomes this severe. So generally speaking, if I saw a patient that walked into me and said, "Doc, my quality of life is terrible. I can't do the things that I like to do," I said, "I'm certainly willing to talk to you about your non-surgical options and see what may help, but the cat's kind of already out of the bag here. And I don't want to make any bones about it. We could try, but I don't want patients to think that it's going to be the be-all, end-all when it gets this bad." And that's a super challenging thing, because at this point, knee replacement is really clinically indicated based on the images. But if you remember what I said earlier, we don't treat the images, we treat the patient. So there is some a zone of decision-making there. Does all that make sense? You guys understand the differences as far as the progression and severity? Any questions at this point?
There are no set of exercises that could alleviate this?
Unfortunately, not in the manner in which I think you're asking. There's nothing that you can do that's going to give you more space or bring the cartilage back. What you're really looking to do is strengthen those muscles around, which just decreases the stress across those areas that have worn over time. So
I do exercises and it gives me relief for a few hours.
Exactly, because as I said earlier, you activated those muscles. Now they're really helping. Think of it, if you could only ever get into Center City by taking the School Expressway, God forbid, right? If suddenly we opened up all the other paths, West River Drive, Kelly Drive, traffic's going to get a lot better, right? So in this analogy, the Schuylkill River is the bones, and they're just handling it all. When you use the muscles, you're opening up those alternate ways to help move some of that stress, traffic, to make it a little bit easier. Sometimes it's temporary, sometimes it lasts a little bit longer. The key is you want to be able to do what you can and maximize all your options. So the point that I want to make here is if you're not doing some level of exercise, I think it's time to start to think about it. And we'll talk about the choices that you make with exercise in a minute. So, meniscus tear, okay? There are two types of meniscus tears, generally speaking. There is the acute meniscus tear, most commonly seen in athletes. And then there's the more chronic degenerative meniscus tear. Now, you can have acute on chronic, meaning that your meniscus starts to break down over time and then you twist your knee. The problem is that once the breakdown process starts to happen, even if you get an acute tear, the surgical interventions to treat those types of tears are often not as successful as we want them to be. The analogy that I use here is, how many people have hardwood floors in their house, right? You put a carpet down, why? Maybe for sound, but usually to protect the hardwood floor, right? In your knee, the meniscus is like the carpet, protecting everything else underneath it, the cartilage, the bone. If you walk down your hallway for 50 years, what do you think is going to happen to that carpet? It's going to start to break down and wear over time. Now, as you're walking, if you happen to catch a toe and you tear it a little bit, well, the easy answer is just buy a new rug. But let's say that you can't. You're going to try to sew it? Maybe. Most of the time, if it's on the edge, you'll trim it out, try to make it look nice, maybe put something over top of it. Unfortunately, in the knee, if this meniscus starts to break down, and it's been a number of years that you've been using it, you're in your 40s, you're in your 50s, you're in your 60s, it cannot be sewn. It cannot be fixed. What surgeons tend to do is go in and trim those edges, which is essentially taking away what's already trying to do the best that it can to cushion and protect, and removing that, which unfortunately can accelerate the process in the long run. Now, sometimes in the right patient, that's all the options that we have left. So I see construction workers and hardworking guys that are still in their 40s, 50s, and 60s, and they got to still work hard, and we try every option. I do shots, I do medications, we do braces, and they're just not getting better. Sometimes it's our only option, but I always caution everyone, you don't want to get fixated on a meniscus tear when you know you have pre-existing arthritis. Because if you do that, there's a really good chance that you're not going to get the results in pain control that you want, because we cannot undo what's been done. No one wants to believe the reality that once that injury is there, it's kind of part of who you are. Everything thereafter is changed. We will do the best that we can with all of the technology and tools that we have available. But the best surgeon in the world can replace the meniscus, but it'll never be quite like the meniscus that you were born with. And so I have this conversation every day. Question?
You talked about the pain a little bit.
Mhm.
Do you deal with a lot of people that, some people can deal with all that pain and others can't deal with a little? That's the biggest
Correct.
thing I noticed you've been saying.
Completely subjective, and that makes it very challenging because I can't feel your pain, right? And so the key is to try to help the patient understand what the generators are and what we can do, but it's a super challenging problem. I don't know if I would want to feel people's pain, to be honest with you. I think I would consider what a career change if you could do that. But it would be something that would be helpful. We use the tools that we have to try to understand it. That's why sometimes you see those pain scales with the smiley face on one end and the super frowny face on the other. You guys have seen that before? It's called a visual analog scale so that we can all understand visually what does it mean to have 10 out of 10 pain. Because my 10 out of 10 pain might be your 5 out of 10 pain. Question over here?
Are you going to discuss the process that possibly go through to stop you from going from mild OA to medial OA?
Yep.
Or severe?
So that'll really come down to a combination of everything that we're going to talk about from a non-surgical standpoint. Because whenever I see the patient, this is our chance to intervene, treat symptoms, and do things differently moving forward. So we've already talked a lot about exercise, right? And so there are plenty of choices that you can make. Walking is the easiest form of exercise. You put your sneaks on, you put your stuff on, and you go. But every single step you take is stress across the knee. So sometimes it's not the best option when you know you have arthritis. So what it really comes down to is the choices that you make. Anything in the water, less stress across the knee, whether it's swimming or water aerobics. If you're a member of the local YMCA or other gyms, sometimes you have access to a pool. I highly encourage that. What's the problem? You got to like being in the water, right? So if that's not your thing, then that's challenging. Stationary bike or kind of bike out in the community. Non-impact. Can it still cause pain? Absolutely. But it's less stress across the joint. The elliptical or arc trainers or other more of a glide concept, again, no pounding. We talked about resistance training, resistance bands. Strengthening can be helpful. Yoga, Pilates. How many people in here know how to do yoga Pilates? 1, 2, 3. Everybody misses this. It is a low impact form of exercise that as we become wiser in our years can be very helpful because you start to engage muscles that you don't normally use. And this has to do with the concept of biomechanics. How does our body move? We get very efficient at certain muscle groups, our quad muscles, our butt muscles, because those are the muscles that we use all the time, every day to walk up and down steps and to live life. What about our core? What about some of our other hip stabilizers? We don't always engage those in the same manner. So people end up getting these disproportionate shifts in the way that their bodies move. Doing things like yoga and Pilates can help bring those muscles that are falling behind a little bit up to speed. And everything starts with the core if you know what you're doing when it comes to yoga and Pilates. So you have to control this. So it is a good option that can often be something that if you haven't tried it before, I promise you, you're going to feel a little different the next day. In a lot of places there are classes, and don't think that you're too old for something like this. A lot of times there are yoga and Pilates for seniors. Some of the Silver Sneakers program starts to incorporate some things that are in the realm of yoga and Pilates. I'd like to pause for a second. I want to talk about the concept of pain during exercise, okay? There's a difference between discomfort and pain. Discomfort is, this doesn't feel good, but I think I can continue. That's often okay to deal with. Pain limits you. I cannot continue to do X, Y, or Z because I hurt. When you're exercising, if you think that it's something that you can manage, discomfort is okay. You can keep going. If it's something that is so bothersome that you cannot do it while you're doing it, or later that night or the next day, you're so limited, that's pain. You need to stop or back off, Okay, that's a really important concept. Discomfort, pain. Does that make sense?
So one of the things I noticed was I like to be active every day is when my arthritis is really bothering me, I have to stop in between days.
Yep.
And that makes a big difference, to go back to what I normally do,
Correct.
but it still retards what I normally do.
That's a great segue into the next point that I was going to make, which is the concept of rest and diversification. Okay, so our bodies aren't necessarily designed to continue to handle lots of stress as we become older. So taking days off are important, but diversification, just like a good financial portfolio, is also very important. Do different things on different days. The routine as it is, often not helpful because you're exercising the same muscles over and over again at the same interval, so your body gets used to it, and your muscles are only going to work as hard as you make them. So if you're only walking on Mondays and Wednesdays, and that's all you really do, then your muscles are ready to walk on Monday and Wednesday. There is such thing as muscle memory. So I strongly recommend do different things on different days and change it up. Swim on Monday or water aerobics. Take off Tuesday. Walk on Wednesday. Do some Pilates on Thursday. Take off Friday. Go for another walk on Saturday. You guys get the point. But so far, I've covered 8 different forms of exercise, and I'll repeat them again. Swimming, water aerobics, biking, elliptical, walking, resistance training, yoga, Pilates. So that's plenty of options on different things that you can do to keep your bodies active and muscles stronger over time. Okay? Thanks for the segue there.
How about if you just can't, you have to stop and lie down to take the pressure off your body?
Completely reasonable. That's part of that rest, and rest is relative, and if that's also one of those things that's different for everybody, where maybe rest is just taking a day off of doing your extra exercise because you're busy taking care of your housework, or again watching your grandkids or something like that. Or rest is at 2 o'clock, I'm sitting down and I'm taking it easy, and I'm gonna watch the Phillies play bad baseball. So that's the kind of thing that's an individualistic choice. Okay. But yeah, sometimes that's what's required. If you know you had a busy day and your knees are bothering you and you just need some time, take it easy, lie down. Which transitions to me, I have it coming up, but I'll talk about it now. Ice. Ice is nature's anti-inflammatory. Often can be very helpful in scenarios like you're talking about, okay? Where he's bothering you, I need some downtime, I'm gonna take a seat, and I'm gonna get my bag of ice or my ice wrap that you bought at Rite Aid or CVS or order online. 20 minutes of ice that can help the pain and swelling, can control the difference between a bad night of sleep and a good night of sleep. So that's another thing that can be helpful. Important concept. Don't put it directly on your skin, okay? Talked about how our skin time starts to change over time and those terrible things called wrinkles. That's because your thick skin starts to thin, and you can get burns from ice if you leave it on your skin for too long indirectly. So get a tea towel, an old t-shirt, something. Put it between there. My recommendations are 20 minutes on, 40 minutes off. Then if you want, you can repeat. So it's an every hour, kind of on the hour. Most people can't really make it beyond a couple sessions because you got stuff to do or life clip, or you fall asleep or something like that. But ice can be very helpful.
You're saying knee pain when you're walking. Don't walk through the other exercises, elliptical,
I'm sorry.
You get the knee pain walking. You're saying do other exercises?
Correct.
Like
Biking, elliptical,
but how do
swimming.
you prevent, it's really osteoporosis.
That's treated by walking. Yeah, that's a great point. But remember, resistance training, you can still do that on your feet, so you're still weight bearing, but it cuts down on the pounding. And I'm not telling you not to walk at all. I'm saying that if walking causes pain, you want to follow your body and try to limit that pain. So it's a delicate balance, and we definitely talk about that all the time in the office with osteoporosis, because you're absolutely right. Weight-bearing exercises like walking are one of the first-line treatments for osteoporosis. That's a different condition, by the way. Osteoporosis is the slow weakening of bone over time. Okay, think about clothes. Joints tend to wear. Okay, if I wear this shirt for the next 30 years and I keep putting my elbow down, I'm going to get breakdown of the material right at my elbow. Okay, however, the whole thread is going to start to become a little bit more bare over time, and that's what the osteoporosis factor is. And it's a little bit more common in women because of estrogen shifts, but it can happen in men too. Question.
Talk about a Baker's cyst, please, and its relation to everything you've been on.
Great question. And I'll have to include that in my next adaptation of the slide, so thank you. So a Baker's cyst, also known as a popliteal cyst, okay? A Baker's cyst is a natural thing that can happen with arthritis. The lining of the knee, something called the synovium, is where the fluid that comes from swelling is created. There's a lot of structures in the back of the knee: nerves, arteries, veins, tendons, ligaments, muscles, fat, skin. A little portion of that synovium or lining can get stuck between tendons, muscles, and then if your knee swells, some of that fluid can get caught in that part that's stuck. That's a Baker's cyst. We often treat those, but it's still not the primary cause because it can be symptomatic. I definitely see plenty of patients say, I got this pressure in the back of my knee. Front of my knee doesn't feel too bad, but this is like this swelling. It comes from the arthritis. So the arthritis is the primary condition, where a Baker's cyst is a secondary thing that happens because of the arthritis. So my practice style is to tend to focus on the arthritis, control the inflammation, and the Baker's cysts can get better. Sometimes they pop on their own over time. You may have heard of people or had that experience yourself. Sometimes we'll drain them. If I'm putting injections and you're taking medications, we're taking care of the arthritis more in the front of the knee, and it's just not getting better, and I still got this swelling in the back of my knee. Some of my colleagues do ultrasound-guided drainages. It's important. You don't just want to have a doctor sticking a needle back there blindly. Again, there's all that other stuff: nerves, arteries, veins, tendons. You want to know where the needle's going. That's where the ultrasound-guided stuff can be helpful. And it's just a technique that's used to help illustrate where you're working. Does that answer your question? All right. I'll try to get back on track here. So we talked about how the meniscus tear is often degenerative. Addressing the meniscus tear through surgery is highly unlikely to fully treat symptoms in the long term like we want, maybe short-term relief. Mechanical symptoms, that's the one true indication that in most people that are in their 60s and below is an indication for surgery. If I stick a door jamb in this door and I can't open it and close it anymore because of the door jamb, you got to take that door jamb out to get the door to work again, right? So sometimes with particular types of meniscus tears, a portion of that tear gets caught in the joint and actually stops its ability to bend. That's called mechanical symptoms. And that is an indication for surgery, which is usually an arthroscopic procedure. It still doesn't address the arthritis. It's really aimed at addressing that piece that's stuck, that's not allowing the knee to function appropriately. And I think I illustrated this point, but I'm going to say it again because I think it's important. In the setting of moderate to severe arthritis seen on X-ray without mechanical symptoms, no recent injury, an MRI is not necessary because it's not going to change what we do as far as our management plan. Okay? The MRI is not the be-all, end-all. And just the same way that I told you, I don't treat X-rays, I treat patients. I don't treat MRIs, I treat the patients. Sometimes it helps me guide my decisions when clinically appropriate. But it's not a knee-jerk reaction where, oh, I have knee pain. I might have a meniscus tear. Let's get an MRI. That's not practicing good medicine. Okay, does that make sense? Sure. All right. So now to actually get into the treatment. I didn't talk about enough of it. So we talked about a lot about exercise and some of the lifestyle changes. Over-the-counter medications. These are medications. Just give me a second here. Yeah. So again, I touched upon all this. This is kind of my highlight. There's over-the-counter medications, prescription medications that actually act very similar to the over-the-counter medications, cortisone injections. There's a gel lubricant shot, also known as viscosupplementation, and then there's some topicals and other supplements and braces that I'll talk about. So I think we talked about exercise to a pretty good degree here. I'm going to skip over this. If there are more questions about exercise, I can certainly take those at the end. We talked about ice. We talked about how the choices matter. So over-the-counter medications, there's really two groups. There's anti-inflammatory medications known as non-steroidal anti-inflammatory drugs. or NSAIDs. This is ibuprofen, also known as Motrin, also known as Aleve. And there's naproxen. Sorry, see, you and I messed it up. I say it all day long. Ibuprofen, also known as Advil and Motrin. Then there's naproxen, also known as Aleve. These treat inflammation directly, can be very effective, but should be used with caution. I always get a little nervous when I see a patient that comes in and says, I've been taking 800 milligrams of Motrin 3 times a day for 6 years. Okay, why? Increased risk of stomach problems, including bleeding ulcers, which can be life-threatening. Increased risk of kidney dysfunction, particularly worsened in the setting of things like diabetes and high blood pressure. Increased blood pressure, which is already bad if you already have high blood pressure, which could, all of these 3 things can increase your risk of adverse events, including heart attack and stroke. If you pick up any single bottle of Advil, Aleve, Motrin, naproxen, and read the label, everything that I just talked about is mentioned there. And so, you know, recently they, I think, added the black box warning. So the news, as the media always does, you know, took it and ran. But this stuff has been known for years. But people just don't want to pay attention because it does help. And so you want to have that relief and you want to be able to control your own pain and live your life, but you got to be careful. So I often say follow the bottle. It says, if you take this longer for 10 days, you need to contact your physician. It's a very reasonable goal, okay? Because if you're taking it for 10 days and your pain's still not getting under control, you need to come in and see someone like me because there are other options that can be more successful in treating. Question.
What do you think of these other items like arnica gel, Tramule, or Salon Pass gel?
Yep. So at my last kind of slide starts to talk about these kind of things. Unfortunately, there's not a lot of good evidence. This is medical research that shows proven benefit. I never tell patients they can't try anything unless I know that it's unsafe. You may get benefit, you may not. There are plenty of substances that can provide some level of relief. Maybe it's just the placebo effect, which means that you just feel better because you're taking something. But for everything that you just mentioned, there's no evidence because I don't include it in my slide. I will talk about the over-the-counter more supplements that have some level of evidence that shows potentially helpful. Okay, so I'm going to ask you to hold off on that.
Is there an anti-inflammatory that you can take to put one more better?
So typically not. Okay, why? Warfarin, also known as Coumadin, is a blood thinner. Okay, used for conditions like AFib or if you have other cardiac conditions. And when you take medications like Advil, Aleve, or other non-steroidal anti-inflammatories, they also have the tendency to thin the blood to some degree. And then the two of them act synergistically together, which can increase your risk of bleeding. Okay, so not recommended. Which leaves you with things like Tylenol. Now, I included aspirin in the bottom because it really truly is a pain reliever, but it also has some anti-inflammatory and pro-bleeding qualities. So you got to be careful with medications, even like aspirin.
Does Tylenol have anti-inflammatory?
Tylenol is a pain reliever. It works centrally in your brain. It is not anti-inflammatory. And it's either an all or none thing. Either patients take it and it works or it doesn't. It's usually not somewhere in between. Generally fairly safe. Now, if you take it in excessive doses, it can affect your liver function. So you got to be careful. Not just take that all day, every day, all the time. Okay. Prescription medications. 2 groups. The anti-inflammatories, which are very similar to Motrin and Advil and Aleve and naproxen. Only prescription, should be monitored by a physician. Usually you don't have to take them as often throughout the day because they're a little bit stronger. And stronger just means that it takes less of a dose to achieve the same effect. Carries all the same risks and side effects. Pain relievers, narcotics and non-narcotic prescription pain relievers. If you have severe arthritis and all your options are used and you can be a candidate for knee replacement, unfortunately, sometimes this is our only option. But if you haven't explored everything else, I often say that this is like closing the kitchen door when the stove is on fire. When you take these medications, you just don't feel the pain because it doesn't treat the inflammation. If it's your only option, it's not unreasonable, but you want to be very careful with these types of medications. Okay? They also have a considerable amount of side effects that become much more of a concern as we get older. Okay, so that's another really important thing. Any questions on narcotic medications in the use in arthritis?
I just wanted to ask you, do you find that people sometimes get addicted to some of these stronger?
Oh yeah, oh yeah. Okay, unfortunately, it's not necessarily a desire. It's your body becomes physiologically addicted in the sense that you need it. You go through withdrawal if you don't get it, and it tends to escalate where you need more of the medication to get the same effect. So you want it more, your body needs it more, and it takes more to get the same effect, which is why you need to be super careful with these types of medications.
Could you talk about use of like a COX-2 inhibitor instead of an NSAID?
So a COX-2 inhibitor is an NSAID. It's just a particular.
Yeah, use of that as opposed to because of the bleeding problem.
Yeah, and the idea is that a COX-2 inhibitor, the product that's available is Celebrex. Okay, it still carries all of those same risks: increased blood pressure, increased kidney function, still has a bleeding risk, just a little bit lower. Okay. Vioxx, which was the alternative back in the late 90s and early 2000s, they got in trouble because they didn't put it on the label. And when they didn't put it on the label, then people had these risks that were already known. They got sued, and the company went under and pulled it from the market. Celebrex did put it on the label, and so Celebrex is still around. Okay, not a bad option, but I do, but it still needs to be used with the same degree of caution on everything else that I just mentioned. She was first. Okay.
I have a question. I had a knee replacement and I ruptured my patella. I feel that I don't walk properly and now my back is bothering me. How do I correct that?
Super common, and we talked about biomechanics before. And so, you know, the song you learned when you were a kid, the hip bone's connected to the knee bone, the ankle bone. Any little change in one particular joint can affect things upstream and downstream. And so if your knee function is compromised because you had an additional injury in the setting of having a knee replacement, that can absolutely affect your back. It gets a little bit more complicated, and for sake of the group, I can certainly talk to you afterwards, but this is a common problem that I see. And a lot of times you want to address each isolated area of pain, but you also want to maximize function overall.
Is that the kind of condition that they see when you're some sort of knee bracelet?
Potentially, you know, and I think that's an important thing. Anything that I'm talking about could give really good relief or very minimal relief. Sometimes we don't know until we try it, but that's why we discuss our options. I'm going to go up here first because he had his hand raised first. But I'll get you.
So what is the solution for someone who has a and it's all treated that wants to solve this inflammatory problem?
Hold that question. Okay.
About 5 years ago, I had my right knee replaced. Then a few years later, I started having trouble with my left knee. And Dr. Good did the right knee. I went back to him and he gave me shots of cinnamon, which took the pain away, lasted for about 2 years. Then, now I'm having problems again. I went to see Dr. Good. And he recommended I get this new thing, Orthopaedics. And I'm now in my 7th week, and I'm not having any.
That's great. And both of your questions are perfect segues into my next 2 slides. So what do we have? Next option is cortisone. It's a strong anti-inflammatory medication that we put inside the knee. It can be very effective at treating pain locally. It's not without its risks, but most of the risks are local. There is some low level of risk bleeding at the site. I'm sticking a needle in your knee, so there's a very low risk of infection. It's not zero, but we typically use cleaning solutions to try to help reduce that risk. If you have diabetes, it can increase your blood sugar, but this can be a very, very effective option. This is something that I would offer to a gentleman that is on Coumadin because of a fit, okay? It is something that can be repeated over time, safely about 3 or 4 times a year. Unfortunately, the law of diminishing returns exists. The more you get it, the less effective it tends to be over time. but it is something that can be repeated. And I use this almost every day. I can't even tell you how many cortisone injections I give in a week.
Is it variable in terms of individual to individual or how long it'll work? And
Very. Yeah. I say the average is about 6 to 8 weeks. Okay. A lot of people get more. Some people get less. It really sometimes depends on where you fall in the scale. Generally speaking, someone that has more severe arthritis is not going to respond as well to cortisone, and then someone that has less or minimal arthritis. Question over here, I saw a hand.
Yeah, I think you should mention briefly about cortisone flare, because it certainly is one of the negative.
Absolutely. So what this woman is referring to is there is something called a cortisone flare, which happens in a small percentage of patients where a chemical gets inserted into your knee. And you can have a temporary chemical reaction that causes worsening pain and swelling. It's often temporary. Very rarely does it last longer than a week, but it is something, and I answer these phone calls all the time that, doc, you gave me a shot last week and my knee's still killing me. I understand. Patience, ice, take it easy, and you got to give it a chance to work. Every single time I do an injection, I always counsel about the fact that pain can get worse. It can take a couple days, even up to a week before it really truly kicks in. I tend to do the injection with a local anesthetic that you inject also into the knee. So at least if the pain flare starts right away, that the anesthetic is still in there trying to help. Okay?
Do you believe that the new technology of the amnio, injection?
We're going to talk about that in a second. Another one?
Is it true that since it's a steroid, it eats away the tissue after a while?
So it can, particularly when used inappropriately. If you're using it too often or using it really more than 3 or 4 times a year, it can break down some of the tissues. So that's where you really want to follow the guidelines of appropriate use. Okay? Too much of a good thing is a bad thing there. Okay? Any other questions on cortisone injection?
The only time I have pain is when I go to stand up.
Mm-hmm.
And that is the only time. When I'm walking, I'm fine. Should I take cortisone?
Potentially. A lot of times when I see individuals that have your complaints in the office, I really talk about the exercises and strengthening, because the stronger your muscles are, as you start to engage them, they're going to be able to handle it. But sometimes even with cortisone, those are the types of symptoms that tend to linger over time. And it's just a matter of trying to optimize your body to deal with it. All right, I'm going to keep moving here because we're running up into an hour here, and I want to make sure we cover up. So, visco supplementation. The woman in the back here mentioned Synvisc. That's the older product, okay? Hyaluronic acid is a naturally occurring substance within our knee fluid. As we become wiser in our years and arthritis sets in, this fluid goes from very thick and slippery to thin and watery. It doesn't do its job as well. So at some point, scientists figured out that rooster combs, actual rooster combs, are made of this same substance. Synvisc was the original product, or one of the originals, that is literally made of rooster combs. Okay? Unfortunately, in a pretty small but still relative percentage of population, people have a reaction to this type of injection. Orthopaedics is the newer synthetic version made in a lab, not from rooster combs, that has a less occurrence of this reaction, but it achieves the same effect. It lubricates and it cushions. It does not heal and it does not replace. It can be very effective. It does not work for everyone, and insurance covers it twice a year. It's a series of injections. 3, 4 of your insurance covers the 4th, and it builds upon itself. Most patients don't get relief after the first injection. It takes time for a series to accrue, and then you start to get relief. Even then, sometimes it can take up to 6 weeks, and if you read the company's website, they say that, for it to reach its full benefit. One caveat is the data shows that in more severe arthritis, it tends to not be as effective. So if I'm managing a patient, I say it's not unreasonable to try, but don't get your hopes up, because if arthritis is already that bad and the bone is wearing down, lubrication is not really going to make much of a difference. Sometimes, excuse me, Depew, okay, I think, yeah.
What's the difference between that and Monovisc?
Monovisc is a one-time shot that's made by Synvisc, so it's the rooster cone. It's all of the shots condensed into one. I don't do them. It's available, but here's why. All of that fluid, all at once, I can pretty much guarantee you're going to get some level of pain because it's just a lot for the knee to handle. The one time that I typically consider is if someone has a lot of scheduling conflicts and can't get to the office, it's reasonable to try, but my clinical success has been much less with the one-time shot. That's my personal opinion. There is data that shows that it still can be potentially effective over time. So I don't want you to take that as the word from above. That's my personal practice style and opinion.
Do you show less reaction to 3 shots rather than 1?
Yeah, that means that's essentially what I just said.
Chemical reaction.
Well, the chemical reaction is still lower in the Orthovisc than it is in the other products.
Might have to do 3 shots.
Right.
of Synvisc.
Typically, the major reaction, the difference doesn't change that much, but all of that volume at once still can create a temporary reaction. Okay. All right, transitioning to more of the topicals, over-the-counters, and other therapies. Glucosamine and chondroitin, been around for a long time, okay? Decent evidence, but not that great. Glucosamine and chondroitin are 2 naturally occurring substances in cartilage. When you take it by mouth, what's the guarantee that it's going to go directly to your knees? There is none. That being said, some patients like it. You want to try it? My real perspective is financially is really the only burden. You spend some money on a product, maybe it works, maybe it doesn't. You generally want to give it about 6 weeks if it's something you want to explore. Omega-3 fatty acids, fish oil, a little bit better evidence. Why? Omega-3 fatty acids are a natural fundamental building block of our cell structure, okay? So if your body is naturally deficient because you don't take enough omega-3 fatty acids, your cells can be a little bit more likely to have malfunction or within the knee cartilage break down and die. So there's some decent evidence that shows that omega-3 fatty acids can potentially help with cellular function, which can then potentially improve symptoms. Turmeric and or curcumin, or AKA curcumin, is a spice, actually has some anti-inflammatory properties, okay? There is evidence that shows that to some degree it will decrease your total body inflammation and it can help. Also, as a naturally occurring substance, cherry juice tends to be expensive and you got to drink a lot of it, but if you're trying to look for everything you can, cherry juice is something that you can look into. You got to be careful though because there's a lot of sugar, and so if you're having issues with your blood sugar, you don't want to rely upon that regularly, okay? Topicals, not as good as evidence, but things like Aspercreme and Bengay can be helpful in symptom control. This is kind of in the eye of the beholder. If you like it and it helps, use it to your heart's content. Just follow the recommendations on the bottom. We touched upon braces, the medial and lateral unloader. A lot of times I'll use a generic hinged knee sleeve. The hinges on the sides are bars that help support and stabilize. With more support and stability, kind of what we want the muscles to do anyway, it decreases the stress across that joint, can be helpful in controlling symptoms. Other supportive devices like canes and walkers can be helpful. I know that's kind of given into the devices and some people don't like that, but I look at it this way. If using a cane keeps you from falling and breaking your hip because you have knee arthritis, that's a scenario where I strongly recommend it because nothing will change your life more quickly than breaking your hip when you're in your 60s, 70s, and 80s, okay? Future therapies. This is where you guys may have heard of PRP or stem cells with the amnio injections. These are things that are not currently covered by insurance that are more experimental. My perspective is this. When you have more significant arthritis, the damage has been done over time. The idea of using things like PRP, which stands for platelet-rich plasma, and I'm happy to give more details about it at the end, or stem cells, is you're trying to heal or allow things to regrow, right? But if it took 62 years, if you're a 62-year-old patient, for your knee arthritis to get to the point it is, it's unlikely that you're going to be able to go back and make it a 40-year-old knee where your arthritis isn't as severe. Where I think the future is going is we're going to be able to identify people in their 30s and 40s who are going to be at risk for significant arthritis and start to intervene then to protect them later. But everything in this future therapies is all experimental and not covered by insurance. Other countries are way ahead of us, but we have the checks and balances process here in the United States, so it's not covered.
Two questions. One, we found that Voltaren gel helps with topical.
Yep. Yep.
And the other question, do you think using these, these injections will prolong your time before you really need a replacement?
That's really the goal of everything that we're talking about here, which is kind of my last summary statement. Everything that we're doing from a non-surgical standpoint, when the degenerative process is already set in, knowing that it will continue to progress over time to some degree, we're buying time. Voltaren gel is a prescription version of a non-steroidal anti-inflammatory. Can be helpful. Still carries some risk though, because it does get absorbed into your bloodstream. So people on Coumadin or warfarin should still not be using something like Voltaren gel. But there is some role for topicals that are kind of in that realm. Which transitions me to my last slide. What is the end game? I think I've gone over it, but understand that if everything we do from a non-surgical standpoint is not controlling pain and not maintaining function of and quality of life, knee replacement is a consideration. It's an elective procedure. You eventually want it. I'll never tell you that you need it. And as we talked about with exercise, unfortunately, obesity is a perioperative concern. If you have a BMI over 40, it increases your risk considerably for operative complications. And so these are the people that kind of fall into that gap where they're really not a great candidate because of their operative risk, but they still have significant pain. I can try to help manage as best we can, but you want to make sure you're still doing what you need to do to address diet and weight loss in the setting of arthritis. Questions?
You spoke about draining a Baker's cyst. I got into a situation in which the front of the knee also had to be drained. 60 cc's of fluid from the front, 25 from the Baker's cyst. How did that happen?
That's from the inflammation. I don't include it because it's really not a medication therapy, but it is a procedure that can be done in the office. It's really to address acute symptoms where knee becomes inflamed, you get swelling. Sometimes you get caught in this cycle where the swelling won't improve without taking the fluid out. And so a lot of times what I do in the office is I will drain a knee, and if it's been a reasonable amount of time or a patient hasn't had cortisone, then you put cortisone inside the knee, which can then treat the inflammation, decreasing the likelihood that the swelling will return.
Is it common?
Very common. Very common.
If the over-the-counters are helping, but they still have this risk because you're taking 800, quite a hefty stomach. If it's helping, should you taper off? Should you continue?
It's really a matter of understanding the risk and using it as appropriately as you can. I mean, if you can move from a everyday scenario to as needed, or take it in spikes where you know that you had a rough day and you can take it for 5 or 6 days in a row and control your pain and then come off, that's a much safer scenario over time.
Okay.
It's really
you're trying to get on top of it, like you
right.
You're really treating what's there.
Correct. And sometimes it gets a little bit more challenging because you know, if you get stuck in a place where you have pain for weeks, then you do need to get on top of it. But this is always a scenario where I encourage patients, come in, have a conversation, talk about it, understand what your other options are. Because in a scenario like that, you may be having a bad run where I can give you a cortisone injection, that snuffs out the pain for a longer period of time. And then as you're starting to feel it again, you go back on your over-the-counter medication. You manage it here and there until it gets to a point where you can't manage it anymore. Then you come back in.
I just want to let you know, when you said yoga, I got my women's health with email yesterday, and part of the main line is part of this.
Right.
And what happened was I called about all these dates. If somebody that's going to be doing yoga, it's $5 a class, and some of them I think will be at Bryn Mawr Hospital.
Perfect. Thank you for sharing that with the
I
group.
just want to let you know that if you I don't know if anybody knows this, if you belong to the mainline health system, There are so many things, I've gone to so many lectures and so many things the last year or two, I cannot tell you how great it is.
Yeah, knowledge is power. When you know what resources are available and what you're dealing with, you have the ability to make decisions and treat your conditions. So I appreciate you sharing that information with the group. It's hot in here. I'm going to stop. So if anybody else has any questions, feel free to grab me. I'm going to stand over there for a while. Thank you very much.
Thank you.